Hi, I'm Dr. Curt Cunningham. I'm a spectrum psychiatrist. My role is to be part of the integrated behavioral health program that's being brought into the general practice setting. And what we're trying to do here is have it so clinicians are comfortable managing behavioral health issues. And we're going to talk a little bit today about some of the ways that psychiatry specifically is part of that program. We're going to start with our first slide here. Medical health systems are the gateway. I'll just go ahead and read the slide. Depression is the third most common reason for a visit to a medical health center after diabetes and hypertension. 75% of patients with depression indicate a physical complaint as the reason they seek health care. I think there's another slide that you've probably been presented or will be later, which basically shows that in general medical settings, you have about 30% of patients that are either psychiatric patients with medical illnesses, and about another 30% of patients that are medical patients that have behavioral health issues. And so when you think about how significant of a number that is, where you're actually dealing with behavioral health issues, essentially whether that's what you intended or not, in deciding to do medical practice. So we're just trying to find more efficient ways of managing and more proper ways of managing these patients. What's the problem? Our next slide here, high comorbidity between medical and behavioral health conditions, worse health outcomes when behavioral health issues aren't addressed, increased costs when behavioral health issues aren't taken into account as part of the medical visit. Separate systems of care aren't efficient. Certainly, as you well know, sending patients out trying to find psychiatry availability, certainly here in Grand Rapids is difficult. 3 to 6 month waiting list, that sort of thing. So things that can be managed in-house certainly way better for the patients and everyone involved. Common myths about depression and anxiety. It's normal for some people to feel this way. You can snap out of it by thinking positively, just stop worrying. Depression, anxiety is a weakness or lack of faith. People only get depressed, anxious when something bad happens in their life. Depression, anxiety will go away on its own. Antidepressant, anti-anxiety meds will change your personality. Talking about depression, anxiety will only make it worse. I mean, these are things that obviously patients struggle with in understanding some of the behavioral health issues that they present with. There's certainly issues with clinicians in terms of biases or lack of education and misunderstanding on their part. So these are some of the things that, as clinicians, that we're faced with in the not only in general medical settings, but certainly in specialty settings as well. Risk factors for depression and anxiety disorder. Being female, childbearing age women are twice as likely to have a mood disorder as their male counterparts. Certainly when you look at hormonally related issues, postpartum depressions, premenstrual dysphoria, those sorts of things, obviously specific to women. Trauma, stress due to an illness, stress buildup. Certainly everybody seems to be under stress these days. Personality issues, other mental health disorders, having blood relatives with an anxiety disorder, drugs or alcohol, and certainly we're all aware of all of these factors that are affecting patients in our general medical offices. Just to talk a little bit about medication management, I think most clinicians are comfortable and certainly familiar with SSRIs, SNRIs, maybe to a little lesser extent, but certainly you see Cymbalta and effects are being used fairly liberally in general medicine settings. Tricyclic antidepressants, not used that much for depression these days, used mostly as sleepers with meds like Elavil and Doxepin. MAO inhibitors, I hardly ever see patients on MAO inhibitors coming out of general medical settings, but they certainly are still available and are worth considering. This says dopamine neurotransmitter. The truth is bupropion or slash Wellbutrin isn't very dopaminergic. It's more of a noradrenergic drug, but we see that often used either alone or in combination with an SSRI, and I see generalists being fairly comfortable with that combination. Says others, we have some medicines like mirtazapine or Remeron, and that's also used mostly as a sleeper, kind of a multi-receptor drug. And we can certainly talk more about these issues at a later date, and I'm hoping to be able to come to the offices and we can do some, more of a lunch and learn sort of format or something like that. Our next slide, antidepressants. Become familiar with commonly used antidepressant medications and medication doses. Anticipate patient concerns, side effects, adherence challenges. Certainly know that compliance is one of the bigger issues in prescribing antidepressants, just getting patients to stay with them. Reinforce need for continuation or maintenance treatment to prevent relapse even after the patient feels better. And certainly clinicians are commonly dealing with the whole issue of patients coming in being depressed again because they stopped the medicine because they were feeling better. So very common problem. Talking points. Antidepressants restore a chemical imbalance in the brain. I mean, the truth is there are lots of different paradigms these days in terms of understanding why patients get depressed from the neurochemical side of things, and certainly in understanding why medications work. Many options sometimes need to try plan B or C. I think clinicians can certainly get familiar with algorithms. A lot of times there's a tendency to use 1, 2, and 3 SSRIs before moving to an SNRI, for example. And I think if people are realistic around the idea that maybe the first medication isn't going to necessarily take care of the problem, and to have a comfort level with the algorithms that exist beyond one medication trial. And the idea says may take 2, 4, or even 6 weeks for true effect, and certainly to give patients a realistic idea of how long it takes for these medications to work. And sometimes, I usually tell patients, let's not have any expectations for the first 3 weeks other than just trying to tolerate the drug, because if we can get the drug on board, really the effects from the drug are something we're going to take advantage of further down the road, but the key is to stick with it and not be put off if they're having mild side effects, because they almost always improve. And which our next point, side effects can occur but often resolve in 1 to 2 weeks. Keep taking medications even if feeling better, which we discussed just a minute ago. And the whole idea of once you hone in on the right medicine and the right dose, that the patient is aware that this is a 6 to 12 month commitment, and it'll be evaluated over time. And in deciding, because a lot of patients will say, am I going to have to be on this the rest of my life? And the answer basically that is, well, that's certainly getting ahead of ourselves, and there's nothing about starting this medication that is committing you to a lifetime of taking it. We're really looking at here and now, let's get your mood better and kind of see where it goes. It says check with your doctor before stopping, and which is pretty common, obvious information. And the idea that antidepressants, some people say, I don't want to take meds because I don't want to get addicted, and certainly SSRIs and SNRIs, I mean, all of the antidepressants that are available are not addictive medications. There are a couple meds, and certainly for those of you familiar with Paxil and Effexor, realize that people do experience discontinuation a discontinuation syndrome from those two meds in particular, and those are things we can educate patients about, and obviously have to work on slow tapers. Certainly, it says not just medications, psychotherapy and brief interventions. In mild to moderate depression, psychotherapy is equally as effective as medication. However, both are best. Almost all studies show that these conditions where therapy seems to be pretty close, if not equal to medications, that almost always the combination is better. Psychotherapy can be done as brief interventions, certainly in your offices where we have a behavioral health specialist embedded in the practice. They can do short-term therapy interventions, which are oftentimes very effective. And if the condition really warrants something longer than that, then they can also help establish a psychotherapist outside the practice. The course of treatment and depression treatment, the first thing we try is often helpful, but if not, we have to be systematic about making adjustments. This can take time. This is where the behavioral health specialist can help. Certainly, the BHS can help with things like compliance, things explaining side effects, explaining generally just the process is all very helpful. And the whole idea about being able to really set them up for, this is not something that if you're diabetic and we're giving you insulin, we can check your blood sugar and tell you whether we need to change it a notch here or there. But most of these behavioral health issues have a chronicity about them, and so to help patients understand that we're kind of in this sort of for the long haul as far as, managing their depression and anxiety. And so a lot of these issues are management issues, not necessarily issues that we're curing. And so expectations are a big part of helping people understand what's going on, and that ultimately helps them considerably. So our next slide here, systematic case review. So to just give you a better understanding of what my role as a psychiatrist is in this integrated model, the behavioral health specialist can bring cases where the provider feels not necessarily comfortable with the patient's diagnosis, or not necessarily comfortable with the medications because the patient doesn't seem to be responding to the medication. So any level of complexity that makes the provider less than comfortable, where they might in the past say, oh, well, we're going to have you see a psychiatrist and go through all of the rigmarole of trying to get someone to see a psychiatrist outside the practice. They can instead bring this to the behavioral health specialist, and that person can then bring it to systematic case review. And that's where I am available. They bring the case to conference. We put the chart up and can review the chart. The case is presented, the questions that you as the provider have about the case, and what you would like from the psychiatrist in terms of recommendations then are discussed. And then I can say, okay, if I was seeing this patient in my office based on what's being presented here, this is what I would consider first, and we can generate a little algorithm based on what's presented. And as a provider, you're in charge still of the patient, and you write the scripts, and so it's completely up to you whether you would want to follow through with those recommendations, obviously, but it really gives you a chance to have fairly direct contact with a psychiatric consultation, and we found that just to be very helpful, not only for that particular case, but seems that clinicians have gotten more comfortable just prescribing various meds that might be recommended moving forward. And so cases that originally were brought to SCR after a while tend to not be brought because clinicians are saying, oh, hey, I've seen something like this before, and the last time you recommended such and such, and so they're doing some of those things on their own. So, so those are things that we can certainly talk about in more detail. Again, this is obviously a very brief overview, and I would like certainly the opportunity to be able to meet with your office and just talk about antidepressant algorithms, talk about things like differential diagnosis, particularly bipolar disorder comes up a lot as a situation where generalists are saying, boy, that's where I get uncomfortable, and certainly some of the meds that we normally use, whether it's lithium or Lamictal, might be medicines that people in general setting, physicians in general settings aren't necessarily comfortable with, and so we can talk about those things. So, so yeah, that's the end of the presentation, and I hope this all goes smoothly, and I understand it seems like one more thing to do, but I think ultimately you'll find it to be quite helpful. So thanks for listening.